Thyroid diseases. This is Dr. G.R. Patel, Professor and Head Department of Surgery, Government Medical College, New City Hospital, Surat. Respected medicos, myself, Dr. G.R. Patel, ex-professor of surgery, and 28 years of teaching experience with experience in thyroid surgery. Today we shall discuss about various forms of thyroid disease and the clinical features. As for example, thyroid goiter, solitary thyroid nodule, that is STN, thyroid malignancy, investigations and management, surgical and medical treatment, as well as that of parathyroid. Endocrine system. Thyroid is a part of endocrine system which consists of pituitary gland, thyroid and parathyroid glands, adrenals, pancreas, ovaries, and testes. Endocrine system. Thyroid is a part of endocrine system which consists of primary pituitary gland, thyroid and parathyroid glands, adrenals, pancreas, ovaries, and testes. The endocrine glands secrete hormones which regulate various functions of the body. Regulation of thyroid hormones. Thyroid hormones are TRH, TSH, T3, T4, and reverse T3. Thyroid hormones secretions are regulated by negative feedback mechanism. A decrease in blood thyroid hormone triiodothyronine T3 or thyroxine T4 levels result in the inhibition of thyrotropin releasing hormone and thyrotropin production. The released thyrotropin stimulates synthesis and release of T3 T4 by thyroid, which in turn tends to inhibit further thyrotropin release. THS is thyrotropin, TRH is thyrotropin releasing hormone. What is reverse T3? Reverse T3 is a metabolite of thyroxine, T4. Reverse T3 is considered biologically inactive. It is produced when T4 is converted to reverse T3. Reverse T3 is an inactive form of thyroid hormone that can indicate how the body is managing thyroid functions, particularly during stress or illness. Iodine 123 thyroid scan in a patient with Graves' disease. Tracer uptake is uniform throughout the gland. The 5-hour iodine uptake was high at 53%. This is I-123 scan mm, showing a nodule in the right side of the thyroid, right lobe of thyroid scan. Iodine 123 thyroid scan in the patient with Graves' disease. The 5-hour iodine uptake was elevated at 29%. Note the high level of iodine concentration near the thyroid. Also note the pyramidal lobe, which often is visualized in a hyperstimulated. The core nodule in the right lobe must be addressed in the same way a solitary core nodule in a patient without Graves' disease is evaluated. This is USG of thyroid. USD thyroid ultrasonogram of right lobe of thyroid in the same patient as in image 3. Fine needle aspiration of the nodule prior to iodine 131 treatment did not reveal a carcinoma. So iodine 123 is used for scanning and iodine 131 isotope is used for treatment. That we must remember. I-23 scan of thyroid. Iodine 123 I-20 scan in a patient with palpable nodule in the right neck, a low serum level of thyrotropin, and a slightly elevated serum level of free triiodothyronine. The autonomously functioning nodule only partially suppresses uptake in the remainder of the gland. The 5-hour iodine uptake was mildly elevated at 22%. This is the iodine 121 scanning of multinodular goiter. Scan in a patient with a toxic multinodular goiter. The 5-hour iodine uptake was elevated at 28%. Note the multiple foci of variably increased tracer uptake. This is color flow Doppler of USD thyroid showing the hypervascularity in the thyroid substance. Color flow USD thyroid. Color flow ultrasonogram in the same patient as in image 2. Generalized hypervascularity is visible throughout the gland, which often can be heard as a hum or bruit with stethoscope. This is color flow USD thyroid. Sampling sonogram of thyroid right lobe up from chin to the top of the head. This is the picture of USD thyroid. The thyroid gland has a right lobe and a left lobe connected by a narrow isthmus. The normal weight of the thyroid is 10 to 30 grams. It cannot easily be palpated on physical examination. This is multinodular goiter specimen. This diffusely enlarged thyroid gland is somewhat nodular. This patient was euthyroid. This represents the most common cause for an enlarged thyroid gland and the most common disease of the multinodular goiter. Clinical case presentation, thyroid nodule, thyroid goiter. Any enlargement or nodule of thyroid is called thyroid goiter. Hashimoto's thyroiditis is also a common presentation typically seen in women around the age of 40. Other varieties of thyroid swelling are also seen. Example, as for example, primary thyrotoxicosis, Graves' disease, solitary thyroid nodule, multinodular goiter, and malignant tumors of the thyroid gland. Clinical features. Here is a rare case of Hashimoto's thyroiditis. Hashimoto with Takayasu arteritis has been reported. This Here, a rare case of Hashimoto's thyroiditis with Takayasu arteritis has been reported. A female patient of 18-year-old, history of neck swelling for last 3 years. Swelling uniformly firm in consistency, no nodules. Both sides radial and brachial pulses absent. Prominent bruit over thyroid swelling. Bruit heard over thoracic aorta, posterior, right side chest. A rare case of Hashimoto's thyroiditis with Takayasu arthritis has been reported. Congenital thyroid disorder. Thyroid scan revealed this nodule to be the only functional nodule. If we remove this nodule, we have to put this patient on lifelong replacement therapy. The patient had come to us for getting the nodule removed, but we subjected the patient to our scan and found out that this is the only functioning nodule in this area and there was no normal thyroid in the knee. Abnormal thyroid nodule in children. This is the thyroid nodule. This 8-year-old girl presented with neck swelling of last 6 months duration. Mental development normal. The swelling moves on deglutition. So that confirms that it is thyroid. Thyroid scan revealed this nodule to be the only functional nodule. Abnormal thyroid nodule in children. Again another patient. Three, 3-year-old girl presented with neck swelling of 6 month duration. Swelling moved with protrusion of the tongue. Thyroid scan revealed this nodule to be the only functioning nodules. The thyroid nodule moves with deglutition because it is encased by a pretracheal layer of pretracheal fascia, and pretracheal fascia is attached to the larynx upwards. So whenever there is deglutition, whenever the larynx moves, the thyroid tissue, thyroid gland in the moves craniocaudally in the upward direction and goes down in the original place. So, abnormal thyroid nodule in children must be most patients with abnormal congenital thyroid nodule present in childhood for removal of the nodule for cosmetic purpose. The clinician has to keep in mind that this might be the only functioning thyroid nodule. So, thyroid scan must be done in such patients to find out whether normal thyroid is present or not. If normal thyroid is not found, as in this patient, the abnormally located thyroid nodules must not be surgically removed. If such nodules are removed in childhood, the physical and mental development of the child will be retarded. Thyroglossal cyst. Thyroglossal cyst is congenital abnormality. A cyst developed in the thyroglossal duct, starting from foramen cecum of the tongue to the passes through the hyoid bone and gets attached to the pyramidal lobe of the thyroid. So it is congenital. Still, it can manifest at older age. Thyroglossus cyst in a 65-year-old male patient. The swelling became prominent for last 4 months. Presence of vascular bruit over the upper pole of thyroid swelling is said to be pathognomonic of Graves' disease. Congenital anomalies like thyroglossus and solitary functioning thyroid nodule is also seen. Ectopic thyroid is also seen frequently. Clinical features. Patients usually present with swelling in front of the neck. It may be asymptomatic. Some patients notice the swelling accidentally while looking at the mirror. Some patients may present with pressure symptoms arising due to swelling. Example, dysphagia, difficulty in swallowing. Hoarseness of voice due to compression or stretching of the recurrent laryngeal nerve or due to infiltration of nerve in malignancy of thyroid. Patient may also present with symptoms of hyperthyroidism like intense sweating, tremor in hands, thyroid acropathy, wasting of proximal muscles of extremities. Patient complain of difficulty in squatting, position in the toilet. Patient may present with symptoms of sympathetic system overactivity, as for example, palpitation, tachycardia, hyperdynamic circulation, as evident by water hammer pulse, increased perspiration, difference between systolic and diastolic blood pressure, diarrhea, and increased appetite. There may be a history of significant weight loss. Female patients may have menstrual irregularities in the form of oligomenorrhea, hyperthyroidism, or menorrhagia. Hypothyroidism. Patient may also present with puffiness of face and generalized swelling all over the body with weight gain. Patient may also present with symptoms of exophthalmos, that is, staring look, frequent blinking of eyelids, injected and red conjunctiva, or ophthalmoplegia. Malignant exophthalmos is a condition of severe exophthalmos with corneal ulceration. Clinical features of thyrotoxicosis, common problem with an overactive thyroid and too much thyroid hormone, feeling too hot when others are comfortable, shakes and tremors of your hand, feeling nervous and irritable, sweating more than you used to, fingernails growing faster, muscle sickness, especially thighs and upper arm, faster heart rate, sometimes irregular rhythm and erratic pulse, that is cardiac arrhythmia, more frequent and looser bowel movement. For women, lighter periods as well as difficulties in becoming pregnant or in carrying the child to term. For men, loss of interest in sex, erectile dysfunction. Eyes that appear larger than normal. Common problems with an underactive thyroid and too little thyroid hormone. Feeling tired and listless. Feeling chilly, especially when other people are comfortable. Dry skin, hair loss, constipation, slow growing and brittle fingernails, slow heart rate, leg cramps, sore muscles, depression, exophthalmos historical. Perry first described diffuse toxic goiter and process in 1786. In 1835, Graves described a female patient. It was now observed that the eyes assumed singular appearance, for the eyeballs were apparently pushed out, so that when she slept or tried to shut her eyes, the eyelids were incapable of closing. When the eyes were open, the white sclerotic could be seen to a breadth of several lines around the cornea. Brain made most telling statement about thyroid ophthalmopathy when he wrote, "There is an exception to every statement that can be made." More than 40 theories to account for development of eye stages in the hyperthyroidism. Von Besdow hypothesized that the orbital content were probably hypertrophic, too much hypertrophic. The disproved hypothesis for thyroid ophthalmopathy includes cervical sympathetic stimulation, laxity of extraocular muscles, orbital venous congestion, contraction of the non-striated orbital musculoskeletal, the presence of simple non-striated orbital muscles, the presence of simple pituitary tract. Exophthalmos historical, thyroid and euthyroid ophthalmopathy. There are many descriptive terms which I will be enumerating. Thyrotoxic exophthalmos, progressive exophthalmos, malignant exophthalmos, exophthalmic ophthalmoplegia, thyrotropic ophthalmoplegia, hyperophthalmopathic form of Graves' disease, and edematous exophthalmos of endocrine origin, infiltrative ophthalmopathy, endocrine exophthalmos, exophthalmic goiter, postoperative exophthalmos. This is the slide of benign thyroid, large deposited colloid surrounded by follicular cells. Thyroid pathology, benign thyroid, pure colloid form of colloid nodule. Note the, note the parchment-like appearance and the cracking artifact in the diff to extent. Benign thyroid again, histological section of the thyroid removed, removed and corresponding to figure B. Thyroid pathology, benign thyroid C cells, immunostain for calcitonin by immunostain. Thyroid pathology, benign follicular cells forming the flat sheets with the honeycomb pattern. Benign follicular cells, cluster of normal follicular cells were dispersed with dispersed cells in the background. Thyroid follicle in benign goiter, several colloid cysts are visible. Thyroid follicles in the benign goiter lift an entire three-dimensional intact thyroid follicle, broken right side broken up follicles with small colloid. Thyroid follicles in benign goiter, tightly packed, compact, commonly observed in benign colloid goiter. Note the abundant cytoplasm seen under high magnification and deep quick stain. The term has been attached to this formation. Thyroid follicle in benign goiters, histological section of thyroid. Note the variability in the size of the acini. Macrophages in colloid goiters. Numerous large macrophages have accumulated cytoplasm in the next to sheets of follicular cells. Hyperthyroidism, that is Graves' disease. These are accumulated cells, tall cells, Hashimoto's thyroiditis, scattered lymphocytes, and large Hurther cell. Hashimoto's thyroiditis, a Hurther cell showing an internuclear cytoplasm inclusion. Hashimoto's thyroiditis showing follicular atrophy. Hyperthyroidism, the cells of the acini appear flat because the hormone is released into the cavity. Hyperthyroidism, the flat cells are visible. Hyperthyroidism, again the cells surrounding the acini are visible flat. Multinodular goiter, the follicles are irregularly enlarged which flattened epithelium consistent with the inactivity. In this microscopic appearance at low power of a multinodular goiter, the earlier phase of diffuse non-toxic goiter leading up to this point may have resulted from either endemic goiter seen in parts of the world where dietary deficiency of iodine may occur, or the uncommon, non-endemic, or sporadic goiter. Young adult women are most often affected. In one era of thyroid metabolism hormone biosynthesis fields leading to goiter is extremely uncommon. C cells. The immunoperoxidase stain with antibody to calcitonin identifies the C cells, parafollicular cells of the thyroid interstitium between the follicle or adjacent to the epithelium of follicles. These cells produce calcitonin, which is a tumor marker for thyroid. Hashimoto's thyroiditis. This is a low power microscopic view of the thyroid with Hashimoto's thyroiditis. Note the lymphoid follicle at the right center. This is an autoimmune disease and often anti-thyroglobulin and antimicrosomal anti-thyroid peroxidase antibodies can be detected. Other autoimmune diseases such as Addison's disease or pernicious anemia may also be present. Both thyroid growth immunoglobulin (TGI) and thyroid stimulating immunoglobulins (TSI) are present through blocking antibodies to TSI. This high-power microscopic view of the thyroid with Hashimoto's thyroiditis demonstrates the pink Hurter cell at the center and the right. The lymphoid follicle is at the left. Hashimoto's thyroiditis initially leads to painless enlargement of the thyroid and later on atrophy. Autoimmune thyroiditis. This is an example of an autoimmunofluorescence test positive for antimicrosomal antibodies. One of the autoantibodies that can be seen with autoimmune diseases of the thyroid. A major component of the antimicrosomal antigen is thyroid peroxidase, which is often measured serologically. Note the high Note the bright green fluorescence in the thyroid epithelial cell, whereas the colloid in the center of the follicle is dark. Here is an example of immunofluorescence positivity for antithyroglobulin antibodies. Patients with Hashimoto's thyroiditis may also have other autoimmune conditions, including Graves' disease, systemic lupus erythematosus, rheumatoid arthritis, pernicious anemia, and Sjogren's syndrome. D. Corwan's disease. This is a subacute granulomatous thyroiditis, D. Corwan's disease, which probably follows a viral infection and leads to a painful enlarged thyroid. This disease is usually self-limited over weeks to months, and the patients return to euthyroid state. Note the foreign body giant cells within the high power field. Follicular adenoma. Normal thyroid follicles appear at the lower right corner. The follicular adenoma is at the center of the upper left. This adenoma is a well-differentiated neoplasm because it closely resembles normal tissue. The follicles of the adenoma contains colloid, but there is greater variability in size than the normal. Hashimoto's thyroid. This symmetrically small thyroid gland demonstrates atrophy. This patient was Hypothyroid. This is the end result of Hashimoto's thyroiditis. Initially, the thyroid is enlarged, and there may be transient hyperthyroidism followed by euthyroid state, and then hypothyroidism with eventual atrophy years later. Hashimoto's thyroiditis results from abnormal T cells activation and the T cell stimulations from variety of causes, variety of autoimmune disease. This is papillary carcinoma of the thyroid. This is microscopic appearance of papillary carcinoma of thyroid. The fronts of tissues have thin fibrovascular coats. The fronts have an overall papillary patterns. There is no such thing as a papillary adenoma, and all papillary neoplasm of the thyroid should be called malignant. Papillary carcinoma of thyroid. This is another papillary carcinoma of thyroid. Note the small samoma body in the center. The cells of the neoplasm have clear nuclei. Papillary carcinomas are indolent tumors that have a long survival even with metastasis. The most favorite site of metastasis is to local lymph nodes in the neck. In fact, some papillary carcinoma may be present throughout life. Metastasis. Medullary carcinoma of thyroid. At the center of the right is medullary carcinoma of thyroid. The far right is pink higher material with the appearance of amyloid. These neoplasms are derived from the thyroid season and therefore have neuroendocrine features which such as secretion of cal- calcitonin. Medullary carcinoma of the thyroid. Here, the amyloidostoma of the medullary thyroid carcinoma has been stained with Congo red. Medullary carcinomas can be sporadic or familial. The familial kind are associated with multiple endocrine neoplasia syndrome, MEN. 2. Chest X-ray of the patient showing multiple rounded lesions secondary from papillary carcinoma. MR scan of patient demonstrating in the axial view substantial process of both eyes but only a moderate overall enlargement of the horizontal rectus muscle. Third, MR of thyroid. In the coronal view, all rectus muscles are cross-sectioned at a fairly posterior position. At this level, the enlargement becomes space-occupying, causing proper contrast enhanced T1 MR fat-saturated scan showing a high degree of inflammation in the extraocular muscles of both orbits. At this level, represented by lateral rectus and medial rectus, the gadolinium contrast has accumulated in the peripheral parts of the muscle but also diffusely stained the orbit fat tissue to form the typical inflammatory picture of this thyroid orbitopathy. This is the exophthalmos. You can see the sclera is seen above as well as below the corneal margin, the limbus. Primary, primary thyrotoxicosis, no exophthalmos. Thyrotoxicosis is enlarged isthmus is synonymous with the hyperthyroidism. This is the enlarged isthmus seen in this lady. Euthyroid goiter, no retardation of physical or mental growth. Mm, Boy, euthyroid goiter, prominent veins are seen on the surface. The identity of the patient becomes evident because thyroid disease may present with ophthalmopathy, so eyes cannot be covered and uh, identity of the patient is difficult to hide in thyroid disease. This is Hashimoto's thyroiditis with pulseless disease or Takayasu arteritis. MRI angiography showing narrowing of the left common carotid artery in this patient. Hashimoto's thyroiditis with Takayasu arteritis. Various collections, various patients, we have got collections. Breast calcification in the aorta. 18 years old girl. Breast calcification in the aorta. Solitary thyroid nodule. STN, very common presentation. Patients have got tattoo marks with the hope of getting it cured. Secondary thyrotoxicosis, toxic multinodular goiter. This patient was operated for cervical spines from the right side of the neck. Toxic multi Toxic multinodular goiter, coronal incision for subtotal thyroidectomy or near total thyroidectomy. Toxic multinodular goiter in this lady has been operated on the collar incision. This is a specimen that was removed in subtotal thyroidectomy. Another specimen, subcut section, multinodular goiter in this lady. Multinodular goiter, thyroid goiter with intrathoracic extension, so prominent veins on the front of the chest or sternum. Prominent neck veins are seen. Intrathoracic extension. Prominent neck veins suggest that there is intrathoracic extension. Multinodular goiter in a young girl. Multinodular goiter, common presentation. Patient was subjected to STT. Multinodular goiter, STT specimen have been excised. STT specimen, multiple nodules are seen. The isthmus also has been removed. Multinodular goiter specimen. Multinodular goiter, STT specimen. Follicular carcinoma in male patient thyroid swelling usually indicates that patient is having thyroid malignancy. Follicular carcinoma in this patient. Toxic adenoma, this patient. Pulse rate 120 per minute. No eye signs, no complaint except cosmetic. Thyrotoxicosis patient. Compression of the trachea in a thyrotoxic patient. This is called seborrheic trachea. Graves disease treated with neomercazole. Patient did not turn up follow-up and developed hypothyroidism. Thyroid solitary nodule in a young girl, which was removed by endoscopic instrument. Primary thyrotoxicosis, you can see the staring look of ophthalmos, patient thin and lean, with versatile thyroid. primary thyrotoxicosis, versatile swelling, the neck, primary thyrotoxicosis, no exophthalmos. This is follicular adenoma in a patient, which was excised. Minimum surgery for adenoma is a hemithyroidectomy. We do not do nodulectomy. This is the follicular thyroid follicular adenoma. Toxic adenoma in this case, swelling for 6 years, no pressure symptom, palpable 3, trachea shifted to left, audible murmur. 45-year-old daddy, swelling 6 years, stationary, 1 year, no pressure symptom, thrill present, murmur present, 3 sons, severe angular stomatitis. Toxic adenoma in this daddy, thyroid adenoma, no congestion of the face, no intrathoracic extension. Thyroid acropathy is visible, bright skin, less hair, brittle nails. Papillary carcinoma of thyroid, HP report from right follicular type of papillary thyroid carcinoma. Follicular type of papillary thyroid carcinoma in the left thyroid lobe. Mets from hepatocellular carcinoma in the same lobe. Tumor emboli from papillary and hepatocellular carcinoma. Primary thyrotoxicosis. This is another case of thyroid disease, euthyroid with drugs, yes, and normal findings, thyroid uniformly enlarged, no nodules, not fixed. Euthyroid got no eye signs. Subtotal thyroidectomy, collar incision, left lobe of thyroid being operated on. Left lobe of thyroid has been displayed. Superior thyroid no pedicle is skeletonized and nerves and artery are ligated separately. Inferior thyroid artery is ligated in continuity to preserve the nerve supply, preserve the blood supply of the parathyroid. Inferior thyroid artery is ligated as far away as possible. The specimen of STT, primary thyrotoxicosis. This is follicular adenoma, patient with follicular adenoma, primary thyrotoxicosis. Carcinoma thyroid, fixed tender thyroid swelling with severe dysphagia. Multinodular goiter, querimyxedema, puffiness of face is visible. Multinodular goiter, toxic with the secondary thyrotoxicosis. Primary thyrotoxicosis. Primary thyrotoxicosis. This is the cervical spine. X-ray has been taken to know if there is any spondylitis, then intubation becomes difficult during operation. So cervical spine is a very important investigation of thyroid patient. Lactating 6 months, patient on altoxin. Graves disease, deviation of the trachea, there is separate trachea. Primary thyrotoxicosis patient. This is gold sign. Deep injection of conjunctiva is visible, especially temporary. Gold signs, sign of thyrotoxicosis. Primary thyrotoxicosis patient. Primary thyrotoxicosis. No exophthalmia. Primary thyrotoxicosis, 35-year-old, 2 issues, 2 months, amenorrhea, wants MTP. Pulse rate is 100 per minute. Primary thyrotoxicosis, this patient. Multinodular goiter, 24-year-old lady, 2 children, last delivery 7 months, lactating, um, last menstrual period 5 days back. Patient anemic, no eye sense, BP 130 by 80 millimeter of mercury, water hammer pulse is present, rate 86 per minute, no tremors. On examination, irregular swelling, pulsatile, move on deglutition, tracheal shape, multiple nodules are felt, audible murmur. This is the same patient. Patient went for tattoo mark to get it cured with a blind faith, multinodular goiter patient. Lateral view, neck extended position, coral incision for STT in this patient. STT right and left lobe, subtotal thyroidectomy was carried out. STT completed. One of the parathyroid has been removed. This is the specimen of thyroid with the right parathyroid. Post-operative picture. Primary thyrotoxicosis patient, 28 years old, married, 4 years, no issues, amenorrhea, 3 years. Past history of receiving treatment for 18 months. Relapse on cessation of treatment. Primary thyrotoxicosis patient, versatile swelling, papillary carcinoma thyroid with mediastinal extension in this patient. Papillary carcinoma. Patient is having congenital deafness, quadriplegic syndrome in this patient. Advanced papillary carcinoma of thyroid. 60 years age, thyroid swelling, 4 years, received neomercazole treatment, no pressure symptoms, pupillary reaction normal, mediastinal extension present. So cervical sympathetic, now ganglion is not involved. Papillary carcinoma of the thyroid with intrathoracic extension. Patient presented in inoperable state. Papillary carcinoma thyroid with intrathoracic extension. Complaint of thyroid swelling. This lady, since 1.5 years, taking neomercazole, complaint of severe vomiting and diarrhea. Tube ligation has been done. Left supraclavicular multiple discrete nodes are present. So when the lymph nodes are palpable with thyroid swelling, the most probably diagnosis is papillary carcinoma of thyroid clinically. This is multinodular goiter. Male patient, there are very high chances of being malignant. Multinodular goiter, euthyroid, no dysphagia, no hoarseness of voice. MNG, 1 year, lymph nodes not palpable. Secondary thyrotoxicosis, 4 year duration, pulse 120 per minute, BP 210 by 130. Married, no issue. Malignant hypertension, patient presented with malignant hypertension. Multinodular goiter. toxic multinodular goiter, solitary thyroid nodule, infection after FNSC of the nodule, STN follicular carcinoma, multinodular goiter, euthyroid vessel, multinodular goiter, 4 years, asymptomatic, multinodular goiter, asymptomatic, patient presented with thyroid acropathy, bitter nails, shiny skin, and scanty hair on lower leg. Patient presented with severe anemia, persistent vomiting, not responding to treatment. Thyrotoxicosis, married, 3 children, anemic patient, TSH level low. Hashimoto's thyroiditis, this patient presented with clinical features of hyperthyroid. Hashimoto's thyroiditis, this is young girl, 16 years age, thyroid swelling, 4 months, pulse 80 per minute, right upper jugular lymph node, level 3 palpable, no pressure symptoms, gold sign present. Query follicular adenoma, this patient, gold signs obvious, toxic adenoma in this patient. Primary thyrotoxicosis patient, primary thyrotoxicosis, fine tremors of the hands and tongue are present. Carcinoma thyroid, heart swelling and restricted mobility on deglutition, no hoarseness of voice, no dysphagia. Query CA thyroid swelling in male, thyroid swelling in male is most likely to be malignant. Heart swelling and restricted mobility on deglutition, no hoarseness of voice, no dysphagia. Carcinoma thyroid, retinoid goiter another patient, age 25 years, married, 4 years, no issues. Bilateral deep jugular supraclavicular lymph nodes are palpable. Bilateral deep jugular and supraclavicular lymph nodes are palpable. Multinodular goiter, supraclavicular lymph node mass, medullary carcinoma of thyroid, medullary supraclavicular lymph node mass. This is visible here. Medullary carcinoma of thyroid, both the sides, both the lobe has been removed. Temporal side of the conjunctiva is injected, that is gold is a sign. Toxic multinodular goiter, gold is a sign. Sorry. Gold is a sign, temporal injection. Follicular adenoma, 55 years age, swelling since man years, no pressure symptoms, trans elimination negative, multiple deep cervical lymph nodes palpable. Pulse rate 84 per minute, query follicular adenoma. Multinodular goiter involving left thyroid lobe and isthmus, 45 years of age, regress partially after treatment, no dysphagia, no hoarseness of voice, pulse rate 82 per minute, BP 140-80 millimeter mercury, USG, right lobe, normal. Multinodular goiter, same patient, multinodular goiter. There is edema over lower limbs, pitting edema over lower limbs. Carcinoma thyroid, 70 years old, swelling in the neck for 40 years, radial increase in size for last 4 months, hoarseness of voice present, carcinoma thyroid, hard nodular mass involving isthmus, right lobe, right upper cervical lymph node palpable, metal, mixed matter and fixed, level 3, trachea shifted, no intrathoracic extension, left lobe of thyroid normal, no lymphadenopathy. This is carcinoma thyroid patient. Say thyroid, trachea compressed, no metastasis in the lungs, multinodular goiter present. Multiple hard thyroid nodules, most with deglutition. Ground nodules are calcified as seen on X-ray. Trachea deviated to right. Cervical lymph nodes are not palpable. Multinodular goiter present. Patchy calcification in the thyroid suggestive of medullary carcinoma of thyroid. Trachea shifted to right. Thyroid dissection, excision of the subtotal thyroidectomy we are doing. Middle thyroid vein ligated is very dangerous because it is short and opens directly into jugular, internal jugular vein. So it has to be controlled meticulously. It should not be torn, and it is short. So this is a danger point for thyroid surgery. Left recurrent laryngeal nerve identified, and the inferior thyroid artery is being demonstrated. Left left lobe of thyroid, which has been removed with isthmus, aesthetic specimen, solid with nodules, with cavity with nodules are visible. Entity, superior thyroid pedicle is being ligated, skeletonized. Arteries and nerves are ligated separately. This is near total thyroidectomy we are doing. We are dissecting outside the capsule of the thyroid. Thyroid in a young patient, 30 years of age, thyroid swelling since childhood, rapid increase for last 2 years. Pulse 86 per minute, BP 110 by 70, no eye signs, no tremors, local examination, no nodules, firm, uniform, rubbery consistency, no cervical lymphadenopathy, query Hashimoto's thyroiditis, near total thyroidectomy. Yet dissection is outside the capsule of the thyroid. Inferior thyroid artery is ligated, dissected, and skeletonized. Inferior thyroid artery in the recurrent laryngeal nerve is demonstrated. Near total thyroidectomy. Recurrent laryngeal nerve and inferior thyroid artery has been dissected. Near total thyroidectomy. This is the thyroid build after excision, after removal of the thyroid. Multinodular goiter again, calcified nodules are visible. Cut section shows calcification in the thyroid. Follicular adenoma thyroid. Follicular adenoma of the thyroid. This patient presented with multinodular goiter, euthyroid, history of thyroid swelling for 5 years, history of decrease in the size with medicine, 2 children, 2 years and 5 years and 2 years, 2 children, menstrual history regular, no eye signs, pulse 88 per minute regular, BP 130 by 80, limit of mercury, multiple nodules, lymph nodes, palpable, multinodular goiter, thyroid swelling, multinodular goiter, quadrifollicular adenoma. 33 years, tremors and excessive sweating for last 4 to 5 years, neck swelling for last 5 to 6 months, eye signs present, BP 136/78, pulse rate 96 per minute, irregular, water hammer pulse is present, hand tremors are present, thyroid swelling, nodular, form and consistency, no cervical lymph nodes, no bruit. Koilonychia present, patient has been put on omeprazole and propranolol. So thyrotoxicosis can develop in a male patient as well. Patient presented with primary thyrotoxicosis. This is Hashimoto's thyroiditis. Neck swelling, 8 months, no pressure symptoms, alcoholic, tobacco chewing, husband died of tuberculosis, 3 daughters and 2 sons. History of tube ligation, pulse 84 per minute, BP 40, 140/90 millimeter of mercury, thyroid form uniform, rubbery consistency, no nodules, no palpable lymph nodes. The Hashimoto's thyroiditis. Medullary carcinoma of thyroid with skull metastasis and mediastinal compression. Carcinoma thyroid, neck swelling since childhood, scalp swelling for last 6 months, thyroid hard, nodular, mobile, only right lobe involved, cervical lymph nodes not palpable, liver not palpable, left shoulder swollen, movements restricted, breast normal, 1 son, husband hemiplegic, carcinoma thyroid, pulsatile scalp metastasis, cervical disease, Graves' disease, thyroid uniformly analyzed, butterfly and said, no palpable nodules, no murmur, no cervical lymph nodes. Graves' disease, patient had signs of toxicosis, pulse 110, 112 per minute, BP 110/70 millimeter of mercury, no eye signs, no tremors. Graves' disease, no exophthalmos. Graves' disease, no eye signs, no tongue tremors, no preorbital myxedema. Solitary thyroid nodules, midline swelling, 3 years, 3 children, euthyroid, pulse rate 78 per minute, BP 130/80 millimeter of mercury, no eye signs. Multinodular goiter, this is again multinodular goiter, thyroid calcification in multinodular goiter present, multinodular goiter XRHs, trachea is deviated, compressed, subclinical hyperthyroidism, where TSH is low, T3, T4 are higher, but the TSH is low. Multinodular goiter carcinoma thyroid, T3, T4 high, TSH low, 12th nerve palsy, deviation of the tongue, right 12th nerve palsy, indicating carcinoma of the thyroid, cervical lymph nodes not enlarged, calcification present, solitary thyroid nodule in this patient. 6 month duration, no pressure symptoms, patient on altoxin and smoking, pulse 84 per minute, BP 130/70, water hammer pulse. When patient was subjected to radical neck dissection on left side, and the node was adherent to jugular vein, so it was saved of no thyroid ectopathy.